Good evening, Dr. Phil here. Today we'll be discussing on malignant hyperthermia part 2. Differential diagnosis for MH includes inadequate anesthesia and/or analgesia, insufficient ventilation or rebreathing, inadequate fresh gas flow, laparoscopic surgery, tourniquet ischemia, sepsis, inappropriate breathing circuit, machine malfunction, anaphylaxis, cerebral ischemia, thyroid storm, ecstasy, pheochromocytoma, neuromuscular disorders, serotonin syndrome, neuroleptic malignant syndrome. This table compares MH with neuroleptic malignant syndrome and serotonin syndrome. For MH, the trigger agent is inhalational anesthetics or suxametonium. For NMS, the trigger agent is antipsychotics, anti-Parkinsonian drugs or antidepressants. For serotonin syndrome, the trigger agent is serotonergic agents or methylene blue. The onset for MH is minutes to hours, onset for NMS is days to weeks, and onset for serotonin syndrome is hours. The presentation for malignant hyperthermia has been discussed in part 1. For NMS, the patient is catatonic, mute, there is lead pipe rigidity, hyporeflexia, tremor, and bradykinesia. There is autonomic instability such as hyperthermia, tachycardia, arrhythmias, tachypnea, labile BP, diaphoresis, siluria, incontinence, or urinary retention. In serotonin syndrome, the patient is confused, agitated, or comatose. There is myoclonus, hyperreflexia, muscle rigidity is less severe, tremors, convulsions, ataxia, and hyperkinesia. There is autonomic instability as well, presenting as tachycardia, arrhythmias, labile BP, fever, diaphoresis or siluria, diarrhea, and mydriasis. Other differential diagnoses for MH includes other causes of hyperthermia such as hypothalamic lesions, increased heat production due to exercise, drugs such as the trigger agents for NMS, salicylate poisoning, cocaine poisoning, or MDMA. Hyperthyroidism, pheochromocytoma, status epilepticus, and tetanus can increase heat production. Hyperthermia can be caused by causes of reduction in heat loss such as autonomic neuropathy, drugs such as anticholinergic drugs, phenothiazines, and NMS, dehydration, or excessive warming. Management of malignant hyperthermia. Immediate management. Call for additional help. Multiple simultaneous actions are required to optimally manage MH. As much help as possible should be summoned. Consider asking help from the surgical team and scrub staff if extra help is necessary. Assess airway, breathing, and circulation. Discontinue MH triggers. Turn off all volatile agents and avoid further suxametonium. Employ activated charcoal filters if available. Insert one filter at each of the inspiratory and expiratory ports and follow the manufacturer's instructions. These filters absorb volatile anesthetic agents and prevents them from reaching the patient. After its application, an anesthetic machine is rendered volatile-free, less than 5 parts per million within 90 seconds. The same anesthetic machine can continue to be used rather than ventilating the patient with an ambu bag while waiting for a vapor-free machine and dantrolene. If charcoal filters are unavailable, have an assistant manually hyperventilate the patient's lungs using a non-rebreathing circuit, such as a self-inflating bag and oxygen, while removing excess volatile agent from the anesthetic machine by flushing the breathing system with maximum oxygen and airflows for 5 minutes, removing old soda lime and replacing it with new soda lime, switching to a fresh breathing circuit, and obtaining an anesthetic vapor-free machine if available. If no assistant is available to ventilate the patient, hyperventilate the patient with 100% oxygen at 15 liters per minute. High fresh gas flow is required to flush out volatile agents, expired carbon dioxide, and to maximize oxygen delivery. Maintain anesthesia with total intravenous anesthesia. Communicate with the surgical team about the possible malignant hyperthermia episode. Stop the surgery if feasible. If not, call for senior surgical expertise to conclude the surgery as quickly as is safely possible. Dantrolene. Dantrolene is a hydantoin skeletal muscle relaxant. It is the only available specific treatment for malignant hyperthermia. Mechanism of action. It binds to ryanodine receptor and limits entry of calcium into myocytes. Other indications for dantrolene includes for muscle spasticity and NMS. Regarding the dose for MH, starting dose is IV 2.5 mg per kg and further doses of 1 mg per kg every 5 minutes until the metabolic signs such as tachycardia, hypercapnia, and hyperthermia are resolving. Pause dantrolene and observe when EtCO2 is less than 45 mmHg and core temperature less than 38.5 degrees Celsius. Maximum total dose is quoted as 10 mg per kg. If there is no response after 10 mg per kg, the prognosis may be grim. The presumptive diagnosis of malignant hyperthermia should be reviewed. Formulation of dantrolene. Dantrolene is presented in vials of 20 mg orange powder, so about 10 vials are required for a 80 kg adult to achieve 2.5 mg per kg. The dry powder form has a shelf life of 9 months. It is formulated with 3 grams of mannitol and sodium hydroxide per ampule. Each ampule requires mixing with 60 ml water for injection. This is time consuming. One way to mix dantrolene rapidly is by emptying several ampules into a sterile dish and adding a large volume of sterile water. One person should be assigned the responsibility of continuously preparing dantrolene. The prepared solution is irritant, pH 9 to 10, thus infused into a large vein. The solution lasts for 6 hours at 15 to 30 degrees Celsius once prepared. Half-life of dantrolene is 6 to 10 hours. Adverse effects of dantrolene includes muscle weakness, sedation, venous thrombosis, and tissue necrosis if extravasation. Hepatotoxicity after prolonged oral use. Establish adequate IV access. White ball cannulas and central venous lines should be available. Reduce core temperature. Discontinue all active and passive warming techniques wherever possible. Active cooling measures includes ice to the groin and axilla, cold fluids such as normal saline into IV lines, the bladder via a urinary catheter, the stomach via a nasogastric tube, and irrigation of body cavities when possible. Use fans, sponging, and for exceptional circumstances, cardiopulmonary bypass. If temperature falls below 38.5 degrees Celsius, aggressive cooling should be paused to avoid hypothermic overshoot. Monitoring includes routine monitoring such as SpO2, ECG, NIBP, EtCO2, core temperature, and multi-gas analysis. Insert arterial line for intra-arterial blood pressure and for blood investigations. Bladder catheter should be inserted for urine output measurement and urine investigations such as urine myoglobin and for active cooling. Investigations that should be ordered includes serum electrolytes, especially potassium, arterial blood gases, creatinine kinase, serum glucose, clotting studies, renal function and liver function tests, urine myoglobin. Correct abnormalities. For hyperkalemia, administer 10 units of insulin in 50 ml of 50% dextrose over 5 minutes. Calcium chloride should be administered only if hyperkalemia is imminently life-threatening. Administering calcium may sustain skeletal muscle cell calcium overload in MH. The dose is IV 0.1 millimoles per kg. For acidosis, hyperventilate to correct respiratory acidosis. If pH is less than 7.2, consider administering sodium bicarbonate. However, take note that bicarbonate plus hydrogen ions produces more CO2. Hemofiltration is the last resort for refractory acidosis and hyperkalemia. For increased myoglobin and CK, myoglobin causes renal damage by precipitation in the renal tubules and stimulating lipid peroxidation. To reduce renal damage caused by myoglobin, provide adequate hydration, and diuresis, aim 2 ml per kg per hour urine output. Dantrolene contains mannitol. However, if diuresis is inadequate, administer furosemide. Urinary alkalinization reduces tubular precipitation of myoglobin, reduces lipid peroxidation, and there is no evidence of harm. There is evidence that paracetamol reduces renal lipid peroxidation and kidney injury in animal models of MH. Hemofiltration can be used to treat increased myoglobin levels. Treatment of arrhythmias. Avoid calcium channel blockers, which may cause severe myocardial depression and hyperkalemia in combination with dantrolene. Treat arrhythmias with magnesium, amiodarone or beta blockers such as esmolol or metoprolol. Correct all electrolyte abnormalities. DIVC. MH results in consumptive coagulopathy. Treatment is with platelets and clotting factors. Correct hyperthermia. If cardiac arrest occurs, treat as per ALS guidelines. Corticosteroids. Dexamethasone 4 mg has been advocated by some. Subsequent management. The patient should be admitted to intensive care unit for close monitoring for 24 to 48 hours after a MH episode and for correction of abnormalities as mentioned above. Recurrence of MH can occur up to 14 hours after an initial resolution. Dantrolene 1 mg per kg every 4 to 6 hours or an equivalent amount given as a continuous infusion has been recommended. Inform the patient and their blood relatives that they should be treated as at risk of developing MH under anesthesia until proven otherwise. Confirmation of diagnosis of MH. Refer the patient to a MH investigation unit. The referring anesthetist should provide a narrative account of the MH reaction and copies of all preoperative assessment notes, anesthetic charts, postoperative care unit records, and all investigations, and details of the patient's general practitioner. The MH investigation unit will then communicate to the referring anesthetist, general practitioner, and the patient regarding any need for further testing. All suspected cases and immediate relatives should be tested for MH susceptibility. In vitro contracture test, IVCTs. This is the diagnostic investigation of choice. IVCTs are the only definitive means of demonstrating that an individual is not susceptible to MH. IVCTs are performed at specialist centers to ensure quality control and reproducibility. Test subjects have to travel to the specialist center for muscle biopsy because the tests are done on fresh muscle. Muscle biopsy procedure is done under local anesthesia block, and the vastus muscle of the quadriceps are typically chosen to be biopsied. The size of muscle specimens are 20 to 30 times 3 to 5 times 2 to 3 millimeters. Fresh muscle specimens are immediately placed in Krebs-Henseleit buffer solutions, which is a modification of Ringer solution, and transported immediately to the lab. This solution enables muscle specimens to be viable for up to 5 hours. In vitro halotane, caffeine, ryanodine or chlorocresol contracture tests are performed. The tension in muscle is measured after it is exposed to these agents in increasing concentration. Contractures are induced in susceptible muscle at lower concentrations of the trigger than non-susceptible muscle. The results may be positive, negative, or equivocal. Halotane and caffeine IVCTs are the gold standard with a sensitivity of 97 to 99% and specificity of 78 to 94%. False positive or false negative results may occur. 4-chloro-M-cresol IVCTs increases sensitivity rate of IVCT to 96.1% and specificity rate to 99.0%. Regarding ryanodine IVCTs, kindly refer to the research done by Marco Fitch et al. In 2002. The results of contracture tests with halotane, caffeine, and ryanodine depend on the different MH-associated ryanodine receptor gene mutations. The results are informed to the patient on the same day. IVCTs are not performed in children less than 10 years old in the UK as the test is not sufficiently sensitive. The tested child should weigh more than 30 kg to have adequate muscle mass for biopsy. Role of other investigations. Raised CK and myoglobinuria are suggestive for MH, but these may both be raised in normal patients after they receive succinylcholine. Muscle biopsy and histology may appear normal. Histology may help to exclude an underlying myopathy that may be associated with a non-specific abnormal IVCT response. Histochemical analysis may reveal the presence of cores that may indicate central core disease. The patient diagnosed with a myopathy should have a neurological referral, and if they are considering starting a family, genetic counseling. Regarding genetic testing, this cannot currently exclude susceptibility to MH due to involvement of multiple genes, as mentioned in Part 1, and there are multiple variants. Sensitivity of genetic testing is about 40%. If upon genetic testing a diagnostic variant of MH has been identified, the patient may be diagnosed as MH susceptible. However, if a diagnostic variant of MH has not been identified, the patient should undergo IVCTs to diagnose MH susceptibility. Patients diagnosed with MH susceptibility should wear medic alert bracelets. Action plan for future MH episodes. All anesthetic departments should liaise with the pharmacy to ensure adequate supplies of dantrolene that can be sourced in the event of an MH reaction. 36 dantrolene vials of 20 mg per vial should be immediately available whenever general anesthesia is administered, and availability of a further 24 vials within 1 hour has also been recommended. A MH cart can be prepared which contains dantrolene and the necessary supplies. A MH treatment poster can be placed in the operation room. Prognosis of MH is good if treated appropriately and early. Mortality was 80% prior to dantrolene availability, but this has reduced to less than 5% today. Anesthetic management of MH susceptible patients. Preoperative. Pre-treatment with oral dantrolene is unnecessary, and sedative pre-medication is controversial. Some anesthetists avoid phenothiazines and butyrophenones as they can trigger NMS. However, neuroleptic malignant syndrome and MH are unrelated. Ensure that dantrolene and supportive treatments are readily accessible. Kindly refer to the section on MH treatment for further details. Intraoperatively, avoid MH triggers such as inhalational anesthetics and suxametonium. Provide anesthesia that do not involve MH triggers. Options include total intravenous anesthesia and local anesthetic techniques. Nitrous oxide is considered to be safe. The use of an anesthetic machine not previously exposed to volatile agents was considered mandatory. However, a new breathing system, flushed with fresh gas for 10 to 20 minutes, has been suggested as being adequate. Monitoring includes routine measures, include core temperature monitoring and arterial cannulation. Continue close monitoring post-operatively. These are my references. Thank you.